Or maybe just real brief. We have,
Sure.
I think I know everybody, but well, I guess, is it necessary? You got a point there, Adam. I think we all know each other. So, welcome, Gail.
Hello. Sorry, I was just finishing giving a couple lectures, so a couple minutes late there.
No worries. We are just getting started.
Well, I'll go and get it started. I don't think introductions are necessary. We were all on the same call last time, so I think we all kind of know each other. So, Julia, Adam, if I need to do anything parliamentary, let me know. I think these breakout groups are a little bit more lax in that regard. I don't see past minutes on the agenda. Does anyone see a reason that we need to touch base on those at some point? I don't think it critical as far as that's concerned. So, but tell me if that's something we need to do and approve. Did we take minutes from last meeting?
I don't think we have formal minutes from the last meeting. I think we just kind of, we decided to do the PowerPoint and the flyer. So,
okay, so yeah, so nothing to approve then. So yes, we for sure don't have to. So call to order. We're here. This is kind of our second breakout session to discuss pediatric related Narcan recommendations to current recommendations and guidelines that are out there. And Julie, as you had alluded to, the last meeting we had looked at the ADHS's slide sets that are available to first responders, including law enforcement. We also reviewed some of the standing orders and looked at those slides and that information that was contained. And I think we all refreshed our memory reasonably well on the auto actuators, whether they be nasal aerosol delivery versus the auto injectors for IM delivery. Just as a kind of a reminder, because we're going to talk a little bit about doses, those auto injectors are either the 2 milligram or the 4 milligram, depending on what brand they are. So I think we all came to the conclusion that we could definitely bolster the current education by one, adding pediatric related material to the existing slide set, and then two, at some point making a freestanding presentation that was PED specific in regards to that. Pragmatically, my personal opinion is I think the combined slide set would be the one used most because people's time is valuable, and if they're going to do a CE or an AZ post credit, for this, they'd probably want to go through one slide set and be able to learn the gamut, peds and adults. So, but I think there's value to both. I do. So, so I'm going to open it to the group at this point. Roman numeral number 2 on Adam's agenda: brainstorming discussion. Can anyone give me any input on anything that had occurred on their own homework portion in the interim between the two meetings?
Essentially, I found what a lot of like-minded literature supporting what you had sent out, essentially saying that in higher doses, Narcan is benign if you were wrong about that diagnosis. And so that was the motivation for putting that slide in the slide deck, which we'll look at shortly, regarding Narcan being administered at adult doses. I don't mean to say it like that. Well, administered being via auto injector, which is essentially an adult dose. And so I found quite a bit of literature that was supporting that. And I went ahead and added it to the Workgroups folder for you all to review. And then in addition to that, I took that information and I kind of mixed it with some of the Narcan standalone, the Narcan leave behind training that is on the DHS website. So I was able to kind of take those two things and put them together. And I'll just share the Workgroup collaboration. So you can see that there, that we have this entire kind of resource here that I've kind of added a couple things to that some of you have added some things to, and it's all very much oriented in the same direction. It's all very suggestive of the safety and efficacy of it.
Adam, thank you for adding in the naloxone leave behind. I actually just gave that lecture, and one of the questions I had specifically was about pediatric patients, and specifically about is there an age cutoff for utilizing naloxone leave behind. So I think that's something we can definitely add to that lecture as well. So we've got a few different naloxone lectures out there. So I think definitely one we can add it to.
Absolutely. And when I created these, I was really looking at who the slide set is for, and so I was kind of mixed between two things. Where Dale, you said one of the motives for moving this forward was that you had noticed recently that a pediatric patient had come into the ED never having been administered Narcan while suffering an opioid over. So I imagine that was a paramedic or an EMT, and now so I have that information. And then I created the slide set with respect to EMTs and police officers who's carrying those auto injectors rather than an ampule or oh geez, not an ampule. What's it called? Not a vial. Maybe it is an ampule. Anyway, and so I was trying to split those kind of two audiences.
Yeah.
And so that was very much the reason why I said, well, I put an asterisk next to it saying, should we? And my question behind that was saying, should we start to look at advising if you're unsure, give an adult dose of Narcan? Essentially, is what I was trying to kind of dance around.
Yeah, yeah. And to extend, Adam, on what you're saying, totally agree. Our PEDS trauma coordinator here at Banner University Tucson took it upon herself to actually do kind of a chart review of our past trauma case. And Adam, that was the file, and Julia, I sent you the file of kind of her report and the incident cases. And I'm preaching to the choir here, obviously, but we are getting kids coming in opioid overdoses who are not getting Narcan in the field. So it's a true event anecdotally, and here we have evidence. So, and this is Jen Jones, to give her full credit, was able to put some of this together. So it kind of substantiates where we're going with this. So.
Absolutely. And I think this data set very much agrees with more broad data sets. It just falls right in line with some of the larger data sets from larger studies from more sources of input. And I think it all generally is oriented in the same direction.
Yeah. And if you scroll down, Adam, because that green column, that left green column is the Narcan EMS giving Narcan in the field. And you can see that we're not hitting those. So I think so.
Right. Yeah. Absolutely. And I think which is something that I wanted to kind of go after was I think that generally, despite our providers, or they're good, experienced providers, and the education process to create providers is also adequate, I think that people are just sort of forgetting the pediatrics can be the victims of opioid overdose. Whenever you think of an overdose, you think of a transient, you think of somebody who a frequent flyer or something like this, and it just kind of, the differential goes to the back of your mind.
Yeah, thanks for sharing that, Adam. Adam, do you want to step into your slide set that you put together?
Sure. Yeah, sure. Absolutely. Okay. Can everybody see that well enough? If I change it to presenter mode, I lose my notes. If you need me to change it to full screen, I can do that for you. But like we discussed in the last meeting, we would like to start out with some stats and some figures, and that's what we did here. And this first figure here was pulled directly off of our state reporting, which is to distribute the provider's primary or secondary impression of being an opioid across age groups. And here we see that 15 to 17 is the vast majority, likely to be intentional in that age range of teenagers, or at least 13 and up, likely to be intentional. And that's supported a little bit by this here second graph, which isn't great. It was the only graph I could really find here. Let me go ahead and make it full screen. It's the only graph I could really find that really did a good job at showing this perhaps missing differential from a provider thinking that opioid overdose isn't a possibility. And so my motivation for this graphic was to hopefully remind providers that you need to consider this in your differentials. If at this age, perhaps unintentional, if at this age, perhaps intentional, regardless, we should be including the differential in this in our pediatric patients. So we're not missing them, because it's a simple fix. I 100% agree with you. It's a silly thing to miss. It's null if you're wrong, and quite a bit of benefit. And so here, if you guys can't see it well enough, the triangle indicates unintentional, and you see that over here, a very high value over here as you get younger and younger. And then as you get older and older, the intentional, the square, tends to move up. And so that's just trying to get providers thinking.
Where did this graph come from? We might want to put it on there.
Sure. This was from something that I pulled in, it's in the list of resources in the Naloxone Workgroup, but it was a study done by American Journal. I'm sorry, it was published in the American Journal of Drug and Alcohol Abuse, as was done by a couple of physicians. Maybe I'm missing the exact source, but I believe it to be academic enough to support.
Okay.
If you'd like to read the article, it's actually a very good article. It's in that. I went ahead and put it in the Workgroup's resources. All right. And then, as usual, some sort of a background. And again, the whole idea was to make sure providers are including this in the differential. So again, this is more of just a verbal reinforcement of that idea. As opioid grows in adults, opioids is likely to grow in pediatrics. And so again, some basic objectives. And I wasn't sure, as I was creating this, I wasn't sure if it was if we wanted it to be an adjunct slide set, to be maybe used standalone or incorporated. So if it seems one way or the other, I was kind of between those two extremes. Should I produce this as a standalone item or to be included in that Narcan Leave Behind training? Okay. I plucked out an algorithm, although I'm afraid this is perhaps a little too specific. I mean, it's the algorithm for when you already think there's an opioid overdose, and so it's pretty far zoomed in. This algorithm is used for when you already believe that your patient is suffering from an overdose. But in all three cases, in all three outcomes, again, that consideration of Narcan, you should arrive at least the consideration of Narcan. Dr. Walsh, to your point, you had mentioned that kids can overdose too, kind of an anecdotal type thing. And so I went ahead and used that. I think it's important. I want to keep pushing that message. The only reason providers are missing pediatric overdose is not because they can't recognize them. It's because the differential goes over their head, I believe. And so kind of continuing to push that message of it is possible. All right.
So one thing I'm recognizing that maybe we need to include in some of these would be including the TTTG for altered mental status and overdose. So that would specifically covering that, kind of reminding people that those are really the big times we need to think about that for pediatric patients, and we use the state TTTG for those.
Absolutely. TTTG, AMS for overdose. Okay. Absolutely. Okay. And then some kind of the bulk of the slides is really just trying to get providers to be able to identify. So I kind of stole some slides from the Leave Behind training. I think that are pretty basic and pretty inclusive. And then you'll notice in the corner, I'm not sure if this kind of serves what we're looking for. If because we kind of said that we wanted to make these slides obvious for pediatric patients, and there's a little bit of discussion between perhaps a theme across the back indicating pediatrics, or perhaps a logo. So for its placeholder, I just went ahead and picked a logo, but whatever anyone thinks about that particularly. Again, pulled from the Leave Behind training. And I've just made the change there, Dale. It's not the same. So that was my discussion. If we consider the provider carrying this, if we consider that this might be a police officer or an EMT, it's likely that they'll have not this one, to say the least, nasal spray, this kind of package right here. It's likely that they'll have this type of device, or this intramuscular type of device, this IN device, or this intramuscular type device, which was where I was at with, like, should I say that the dose is the same with respect to those auto devices? And so that was the motivation for the same. But I agree with you, Dale, it's not the same dose. It is 100 mics per kilo.
Yeah. Well, and, here is, educational module, right? We want people to walk away from it believing that they can do this without hurting the kiddo, even if they're wrong. Mm-hmm. So a dedicated slide that is focused on how low the side effect profile is for this medication. So a dedicated slide for side effects. One, I was also kind of hoping to have a slide that focused and put it into perspective. If the dosing of Narcan in kids is 100 mics per kilo per dose, a 10 kilo kid is going to get 0.1, right? A 10 kilo kid's going to get 1 milligram. That means a 30 kilogram kid, which is roughly a 6 to 8 year old, is going to get a 3 milligram. And we're talking about auto applicators that are going to be between 2 and 4. Mm-hmm. So a 40 kilo kid meets dosing. So we're not that far off, So if we kind of spell it out, one, side effect profile is low. Here's how we really dose it in kids, because sometimes we'll have paramedics on scene who will want to aliquote their own dosing and dose appropriately. But if you choose the auto injector, the likelihood of you hurting somebody is going to be is going to be very low, and the effect of not doing it is going to be really bad. Mm-hmm. So I think having a set of slides that kind of follows in that regard. Adam, would you be willing to let me share a slide, just so I wanted to make it
please. Yeah, here.
If I can do that.
This is Gail. I totally agree with Dale's point. I think really specific spelling out those dosing and typical age groups, I think for an EMT kind of helps to paint in their mind why, okay, this isn't that type of dose. It's safe for me to give that.
Are you seeing my screen now?
Yes.
By chance?
I think it really.
All right. Yeah. Thanks, Gail.
So
So this is the one I wanted to show you. Go ahead, Gail. Yep.
The other part too, and I think I just.
Sorry, go ahead. You're breaking up a bit.
I'm sorry, I was going to say the other part I would, driving back from the lecture, so I got bad reception. I'll put it through that if I get a stopping point.
Okay. Well, the floor is yours, Gail, if you want to finish that point.
If you had some brief again, sorry about that. What I was saying is, ADHS has a ton of funding for the intranasal, also in the prepackaged form, and it's probably the safest and easiest to give. I don't have any issue with looking that as our primary recommended formulary. Like, here's how to request your free Narcan for your agency. The Office of Injury Prevention is very willing to give that. So of the options, it doesn't require trying to draw anything up. There's no needles, there's no syringes. It's very safe and easy to use intranasal, and there's funding to get it for free for agencies.
And Gail, you broke up a little bit there. You said the funding is primarily intranasal, not the injectors, correct?
Correct. So ADHS, the Office of Injury Prevention, has a ton of funding to provide naloxone. The only formulary that they are getting is the intranasal 4 milligram dose.
Okay. All right. That's a perfect segue to what I wanted to show here. Thanks, Adam, for letting me share. So this is one of the papers that we had found, and it's a Center for Drug Evaluation and Research, and this is specifically a formal document out of DHHS, okay? And it's reviewing specifically the product of Narcan, and it's Adapt Pharma, and it is their 4 milligram intranasal spray. So again, this is DHHS formally reviewing it, okay? And I'm going to just jump us all the way down. Forgive me for the fast scrolling. No one have a seizure. Right there. And I think there's a lot of money in this conclusion statement. I think we should dedicate a slide to this. The feds are telling us, and I'll read it out loud, Gail, because I know you can't see it. The conclusion of this review document of that Narcan product, intranasal, again, 4 milligram. Conclusion, given the intended use for treatment of life-threatening conditions, the relative ease of use of the proposed IN formulation compared to the IM formulation and the established wide safety margins for naloxone administration of a non-weight-based intranasal naloxone dose of 4 milligrams seems reasonable for pediatric patients from birth to 17 years for emergency treatment of known or suspected opioid overdose until emergency medical services can be provided by trained professionals. And boom, it's there. And I think we should probably have a slide that kind of dedicates this. And we're essentially quoting DHHS medication review. What do you think? And I'll stop sharing.
It really is the entire message, what you're trying to get across. If in doubt, give it, because there's no harm. If you're wrong, it makes no difference. But you've done something. Yeah, well, it's that kind of fire extinguisher. If you have it, not need it, not have it, kind of a thing.
Sure.
I think a statement like that should be upfront, early in the slides, to kind of preface people with the idea that give it. I mean, it's give it pretty freely, it seems like.
Yeah, right when you introduce the product, boom, this is what the feds tell us, for sure.
Okay, absolutely. I'll find a way to work that verbiage in there. Absolutely, as kind of to me, that's like the overall, that's the overriding theme is when in doubt, just give Narcan.
Yeah. And I'm sorry, Adam, I made you not share your slides. Would you mind sharing again?
Oh, sure. Yeah, sorry. Just a few more here. Okay. So you don't want to include the verbiage, the dosage is the same as adults, because for all intents, it's not, but we're trying to push if in doubt. Is that kind of correct?
Yeah.
Okay.
Yeah. Well, I mean, we can introduce them to what true dosing is, because again, paramedics are going to be going through this module too.
Okay.
And they're going to want to dose appropriately because they have the capacity to.
Yeah, and that's, you see there in the notes at the bottom, I said, consider what devices are being carried. And so if you want to also include paramedics, which is kind of what we were talking about at the beginning of the meeting when we said that you had noticed patients coming in, that would be a paramedic transporting them. So the slides need to be made more broad to include paramedics as well.
Yeah, so if we introduce the true science of the dosing, give them kind of a dosing table of essentially showing them that the 6 kilo kit is going to meet adult dosing anyways.
Mm-hmm.
So then we step to, well, what if they're under 40 kilos? And then let's go into the side effects. We'll stay what the feds tell us. And it's just a big, bold slide. Do it. You have concern of opioid overdose, do it.
Sure.
Yeah.
Are you satisfied with this statement that the side effects are rare? Is that sufficient, or do you want to get into some of the particular hemodynamics of?
You know, again, we're going to be speaking to a broad audience. The non-medical person is going to kind of just glance over that. The medical person, the paramedic, is going to want to maybe look at some of those side effect profiles. And, you know, so we could have a slide that states what they are and what the incidence is.
Okay.
So, you know, and again, that makes it an educational module.
Okay, absolutely. All right. I put an asterisk here. I wasn't sure if saying wide safety margin was sufficient, but I think it was exactly just in that statement, in that conclusion that you had found. So I think that's okay.
Yeah, good term.
And this is essentially what you've been saying, but let's beef it up and let's move it forward. And then at the end of the meeting, everybody agreed that we should have a follow-on, something that follows the administration Narcan. So in terms of pediatric resuscitation, these last two slides are with respect to PEDS-specific CPR, whether it be infant or child or something like that as the technique changes. Kind of a generic slide here. I apologize for that. More or less of a segue. And then perhaps so for the paramedics, the left side will be a little bit more useful, and perhaps for law enforcement or EMTs, perhaps the right side is more useful. It's kind of a jumbled slide. I don't intend for them to be on the both slide. I just kind of put them there as concurrent information about pediatric specific. You know, say you give the Narcan and they don't wake up. Well, what to do now? And that's it behooves us to provide that same training in this module. And that's it. That's what I have. And so I didn't want to make it too short or too long. I was trying to play the balance between, should we add it into the leave behind training, or should we have it on its standalone, the ability for it to stand alone? And so that's kind of the motive for the length and the content, but whatever anybody thinks that we ought to do with it.
Yeah, I think we're hitting the larger theme here. It would be nice to make it more robust. I think the slide set for the slide set that's already out there is, oh goodness, it's I'm trying to see how many slides. It's 85 slides. So, you know, we can fill, you know, because a lot of, and again, I'm referring to the PEDS standalone. There's a lot of commonality between the two, right? Because it's an Narcan educational module. And then we insert our PEDS specific slides that you're creating, Adam, into that module, and we'll have two standalones, adult and PEDS. But I think we still need to have a hybrid that will train people on dosing adults and kids in one slide set.
Gotcha.
And I welcome in opinion from the group. Gail, Heather, Julia, what do you think? Tyler?
I think the CPR one's tricky because you have to really look at the audience getting that training. So the law enforcement one, they don't have anything but their hands. So really when I say law enforcement, I train them on hands-only CPR because they're not going to do mouth-to-mouth. So while that's not the best CPR for a kid or for an opioid overdose, if it's that or nothing, I want them to do versus a paramedic or EMS personnel that are going to have equipment to bag or places to robotic. We want them to do those interventions. So it's the only caveat to CPR. We may have to use different slides depending on which slides we have to.
Yeah, and I'm looking through it. It looks like slides 80 through 86 are specifically CPR for law enforcement officers. Yeah, obviously CPR in an infant's a whole lot different.
Mm-hmm. Okay. Yeah, I thought maybe we could thicken these slides up, given some group discussion about what we want to do with them. Yeah, like, you'll notice I'm left off mechanism of action and things like that were well covered in the leave behind training.
Yeah.
Okay. Okay. Let's see. And then we had talked about and then, if anybody has any critiques, comments, questions on the slides, just holler or email me. And then we had discussed the production of a flyer that we could use. And I found on our website, I found a bit of a, I don't know what to call it, I'm trying to do two things at once here, sorry. Educational, Naloxone educational pamphlet that we could use as maybe a springboard and customize it for pediatric use. And it's just these 2 pages, kind of a pamphlet. And you'll see some of the similar.
Is that a trifold?
It is. I made it. I made that flyer, so we can change it. However.
Oh, perfect.
Yeah.
Julia, you're going to give us intellectual property rights?
Yes, you can have it.
And the flyer is excellent. It's really designed to go along for specifically Naloxone leave behind. If we're giving them a kit, that you give them some education on when and how to utilize it, along with resources. If we're looking for statewide, we try to include kind of the OR line, things that were kind of statewide resources. But when, like, for separate jurisdictions who implement this, they can usually put in things that are in their area that are covering additional resources.
Mm-hmm.
Great.
Absolutely. I think we have an opportunity between this with a little bit of modification towards peds and the Phoenix Children's Symposium coming up. We might be able to get something where we can take advantage of that, where we have a lot of providers in one place. Me and Julie were kind of talking about the strategy and what to do with our presence there at the Phoenix Children's MVP Symposium, which is coming up in a couple of weeks here. I think 2 weeks from today.
Do you think they would let you guys set up a table in the vendor area?
Yeah, absolutely. We're registered as a vendor.
Beautiful.
And so we thought we could use that opportunity to push this agenda.
The only question I have, I haven't actually brought this up, Adam, to you, but would we be able to, if we created a flyer, if it wasn't approved, Dr. Bradley, like by the education committee or PACES, like the timeline's a little off, so would we be able to promote something like this, or would we have to wait?
So this educational pamphlet has been approved.
Okay.
I don't know that we actually need to add anything pediatric specific to this. I mean, so I'm trying to think of, like, when I think the blue mnemonic works for any age patient. I'm trying to figure out where and what pediatric specific we would add to this. But really, it's at that symposium, it's really individual EMS providers, so it won't necessarily be like an agency, but we could certainly spread the word that if someone could go back to their agency and say, hey, I'd like to implement this.
Okay. I do. Yeah. Looking at it, it isn't, I mean, you could almost argue it's not even really specific to adults. So it does kind of work a little bit in both directions. I agree.
So I guess we could just have, like, for example, a sign or something that says naloxone. You can give naloxone to pediatric patients, and then we have this flyer that's already been approved. So we have the message with this flyer that's already been approved, something like that. Just an idea.
Sure. Yeah.
Out of curiosity, is there any desire for applying this to laypersons as well, like individuals that have pain medications in a household for children, et cetera? Or is this mainly for professional responders and police?
Well, yeah, I mean, Julie, Adam, you can answer more to that as far as the Department of Health is concerned. But Tyler, there is a very big push. In RED, if I have anybody who requests a Narcan auto injector, I'll prescribe it to them. If you know someone who uses or abuses, whether prescription or street narcotics, I will give you Narcan. And that is a big push, I think, not only throughout Arizona, but nationwide. The appropriate dosing, administration, I don't think that's not necessarily our target audience, but it's there. It's definitely there because it's recognized as a need. So it's just not our audience for this product, at least.
Yeah, I agree with you 100%. The audience is first responders in general, from policemen to paramedics, firefighters. But I mean, to your point, ultimately, the best person is the most proximal person to that, and we are always reactionary. We're not out there in the field waiting for stuff. We're waiting for somebody to call us, and so that would be the best way of doing things, is to get it as far down and disseminated as possible. And so if there, which I haven't thought about that, and I can't come up with any strategy so quickly, but that would be the best case scenario, to get it down to the bottom level. And so we can sort of get ahead of it, so to speak.
So I just
That really is, I'm sorry, go ahead.
No, please go ahead.
I mean, that really is what the Naloxone Loop Behind program is, that we try to advertise, is specifically that. So we're trying to get EMS to start stocking the naloxone and the pamphlets and essentially distributing it throughout their communities on calls.
Mm-hmm.
So that is exactly what the Leave Behind program is designed for. So that's why when I kind of just having given that lecture, I think adding some specific pediatric slides so people know if they encounter a pediatric patient who's around opioids, that they can leave naloxone there as well.
So I just want to put this out there. I'm part of a pretty newly formed group through the College of Medicine, Harm Reduction and Addiction Medicine Interest Group, and we're doing regular outreach events at Sonora Prevention Works. I'm not sure how much familiarity you might have. I would imagine a fair deal. And we're distributing naloxone kits, auto injector kits, in a couple of weeks. And so I know that's going to be an ongoing thing, and I'm not sure how this would apply, but I just wanted to put it out there as that's a potential venue to get that information out in pamphlets like this, to let people know that if you're collecting this for yourself or for loved ones, I just want you to be aware that in the event that a child, underage person, were to become overdosed, you'd be safe to deliver these doses while you're waiting for EMS response, et cetera. I'm not sure what people's thoughts are on that, but just wanted to put it out there.
Good work.
No, it sounds like we're coming to a central point. You're coming from one side and working, so it's excellent. No, I appreciate that. I don't know how, and this might be ignorant for me to say, I'm not sure how aware throughout the entire state that any given paramedic is that they can or have Narcan to leave behind. I don't know. I don't know that when I didn't know. Well, how long has the Leave Behind program been in place for?
It's been approved by statute since 2017. I think the
right?
Bureau, the Bureau has really started in the last 12 months to develop the infrastructure to make an agency. So an individual paramedic or EMT would have to have a medical director in an agency that approves of that. We essentially try to create the curriculum, the educational pamphlet, the standing orders, the guideline, to make it really easy so that someone who wants to implement this really has no legwork. And also, here's a link where you can get your free Narcan from ADHS as well. So that's part of our big push that we've been kind of trying to get around the regional councils and the state and statutory committees, is sharing that message and getting that messaging out there.
That seems like the best way to do it. I agree with you. Okay. Okay, let's see. That's it for the agenda. Does anybody have any additional items that they needed to remark upon or go over?
Well, it's mostly an issue in my mind is marching orders. November 18th are the upcoming meetings. What do we think we can reasonably get done and distributed to education in advance of those meetings? And I think they need them at least a week out, right? Week before?
Yeah, a week or 2 weeks before. So that
2
people
weeks.
can review them. 2 weeks. Okay.
2 weeks or Shelley gets anxious.
So by November 4th, what can we reasonably have done? And again, the goal is maybe we could have this available for our table, particularly the flyer. I like the idea of the flyer. Maybe making a little bit flyer. Did you know that Narcan can be used in kids? Maybe a little flyer that we can actually have on the table at the PACES Symposium.
Mm-hmm.
Mhm.
Yeah,
Yeah,
it's exactly what me and Julia were discussing. Sorry, Julia. That's exactly what me and Julia were discussing, was some medium to hand out regarding this issue.
Okay.
Sorry, Julia, go ahead.
No, you're good. Nothing bad. I was just gonna say, yeah, we can work on that.
For sure.
Well, undoubtedly, your guys' workload is heavy. But do you think, and I'll be honest here, but do you think that that a flyer can be drafted in a week? Because we got to volley it back and forth a little bit through the group. Do you think maybe a week, 2 weeks, and then like a quick turnaround on edits and feedback? And it volleys back and forth 2 or 3 times to become a final draft. What do you think?
I think if Adam and I work really hard to create a product on our end that we could share with you guys within the next, probably be a lot of work for us, but like in terms of just working hard on it for the next couple of days. So if we got it done by like next Wednesday or something like that, maybe we could share it, because it is I think the symposium is the following Tuesday, so it's really not a lot of time. So we really have to like squeeze in a bunch of work, which is fine. I think we would be able to do it. Do you think so, Adam?
No, I agree. I think we can. We had discussed the timeline being a little compressed, but I don't think it's unreasonable to think we can't do. So let's move forward with it. Let's produce. And besides, we already have somewhat of a working flyer. Maybe we can just adjust it, in one direction or another, and so we have a starting place already.
Well, let me ask, and maybe that's where I got confused. The PACES Symposium is what date?
Next Tuesday to date.
Oh,
That's very soon.
so Gail, are we going to be able to put a pamphlet on the ADHS table in the vending area if it's not approved?
That's the tricky thing, because ADHS is really trying to get like logos and not approved. I mean, I think a sign that we just have and up there versus something we hand out. Yeah, I just don't know. I think we'd have to check with Shelley and Rachel and see. Because they've really tried to make sure everything gets kind of approved at a little higher levels since COVID.
Yeah. I and that was my error. I apologize before asking the task. Is I wasn't aware that the symposium was that soon.
Yeah.
Well, we'll definitely have it available for the PACES Symposium in Flagstaff for names.
Sure, for sure.
Mm-hmm.
And I mean, I just hate to have ADHS's name on it without their approval, and then having it available to the public. So
yeah, that was my question earlier in terms of if we're creating this new topic from scratch. Not from scratch, but the group is working on this already. And if we haven't gotten anything approved yet, which I'm sure we will, but yeah, it might be premature to have that information at that particular event. But
well,
sorry.
That being said, if we're really eager to get the information out there, I mean, I work for Banner. I know they may have a table. Actually, they probably have the same misgivings. So disregard. Never mind.
Well, we have Julie and I have a time on Friday specifically slotted out for this, and maybe we can get a rough draft, a real rough draft by then, and push it around and see what people think about it. I have no idea what kind of the process it takes to get something approved.
Yeah, the process, unfortunately, it can take a long time because it has to go through the actual education committee and the actual full PACES committee. And those groups only meet every 4 months.
Yeah, okay. Yeah, they're really working uphill here.
Yeah, so November is soon, but it's not before, it's after the event.
Okay.
So unfortunately for that topic, we probably have to wait on that one.
Yeah.
Okay. So our timeline is production, lobbies back and forth, final draft before November 4th.
Mm-hmm. So yeah, we still have a really tight timeline regardless of the symposium. So yeah.
Yeah, I think that, some generic signage, like, do you know, is Narcan safe for kids? ? Yes. Something, we could have a sign that would not need to go through. But if we're like distributing something, that gets a little trickier. The overall message is Narcan safe for kids? Yes. So, something like that. And then we've got the educational pamphlet that's already approved. We can hand that out. So we can work around some of that before handing out a product that hasn't gone through any approval process. That's where it gets a little tricky.
Very clever.
Yeah.
I could put a sign around my neck that says "Talk to me about Narcan and kids." Just walk around.
There you
go. Okay. Let's see. I think that's good. I think we have a good chunk of work to take care of. Does anybody have anything else?
Not I.
I don't think so.
Okay.
No, sounds good. Thank you, guys.
Okay.
Okay. Do we have to adjourn or anything like that, or I'm unfamiliar with the process?
Signy die. That's when you drop the gavel and say signy die.
Signy die.
I think we're good.
Okay.
Yeah.
All right. I'll make sure to get out a review of this meeting, minutes for the next meeting, and we'll get some scheduling out. Thanks for jumping on that doodle poll and being here. So we'll just kind of continue with that fashion. And we'll look at the next meeting. What do you guys think, given what we've talked about? Should it be sooner or later?
I personally think we should try to do as much work just with email as possible, since there's really not a lot of time. So maybe, unless we want like a quick meeting to really go over what we've created, I'm not sure.
I mean, we could do it November 4th, and then with the premise to the meeting is a final approval of the file that we're sending to Shelley that same day.
That sounds perfect.
Okay, no, we'll shoot for that date then.
Yeah, I don't even know what day November 4th is, but I guess it could be
Thursday.
Thursday, 2 weeks before.
Yeah, it's a Thursday.
Yeah, so I guess we could even do a couple days earlier, depending on schedules. People's schedule allows to. It's up to everybody else. So.
And we can make changes. Shelley just likes to have at least some kind of a placeholder for public comment and review ahead of time. I think there's like a 10 or 14-day rule, so she likes to just have that posted. But if we want to make changes, we can make changes up until the meeting, but at least gives people opportunity to see that it's on the agenda, review it, and potentially be at the meeting if they want public comment.
Mm-hmm. Okay, perfect. Okay, that sounds good. I think we have some work to do. I appreciate everybody being here. Tyler, thanks a lot. Appreciate your all's participation.
Yeah, thank you guys for all your work on this.
All right. Thanks, guys. Appreciate it. We'll see you next time.
Thank you.
Thanks, everybody.
Bye, everybody.
Bye.
Thanks, guys.